This is Mark Newman from Precision Analytical Laboratory, and thanks for letting me drop in on your session today. We're going to be talking about hormone testing in terms of HRT monitoring, as well as just generally speaking, and hopefully give you guys some tools to clear up maybe some situations that are a little bit difficult in terms of knowing how best to test. So in terms of the objectives, what's the need for hormone testing? What types of hormone testing do we have at our disposal? What are the limitations of those? And then a big one is, what effect does a different route of administration have on what we should expect from our lab results? So your objectives, I think, are to treat your patients well. In terms of baseline testing, you can use labs, of course, to know which direction to head. Do I need to add testosterone in, or just estrogen, progesterone? What are we doing with a particular patient to start with? And then in terms of HRT, we want to maximize efficiency and minimize risk, which means we're going to use labs to optimize treatments, but we need to know when that's appropriate and by what means that's appropriate. And ultimately, we're treating patients and not labs. And so we need to, especially though, know the limitations to know how heavily we can lean on the labs and how heavily we need to lean more on patient symptomatology and other factors in scenarios where the labs are a little bit trickier. So in terms of our options, you've got three mediums, of course, to test in: saliva, serum, or urine. What's the difference? There's a lot less hormone in saliva to test, but in terms of what we're actually measuring, if you take, for example, estradiol, or E2, made by the ovaries, and then it's going to get distributed how? By the blood system, right? So it's going to get distributed to all the different tissue, and is it going to get distributed and circulated primarily as a free hormone? No, most of it's going to be protein bound. Right? So most of it's bound to sex hormone binding globulin, SHBG, or albumin. Now, can that complex of protein and a hormone get into saliva or urine? No, it's too big. But the free hormone can get into saliva, and that's what we monitor there. Can the free hormone get into urine? With cortisol, yes, but with the sex hormones, it really doesn't to any great degree. Why? Because it's not water soluble enough until it hits the liver, and elsewhere, but it gets a water-soluble group, like a glucuronide or a sulfate, added on to the molecule, and that can find its way into urine. Bottom line is, three different tests, three different forms. So we're always a little bit of apples and oranges when we're comparing the three, but to a first approximation, when people are making their own hormones, any of the tests should work reasonably well to identify a significant deficiency or an excess. If you take, a 5-year-old girl and a premenopausal woman who's healthy and cycling, and a pregnant woman, you should get a low estrogen, a normal estrogen, and a high estrogen, and you should be able to distinguish between those three with a serum, a saliva, or a urine measurement. When we get into needing to really fine-tune the values, there are some advantages that some of those tests have over another, but generally speaking, we should be telling about the same story. Now, that's the story without HRT. When you add HRT, this is kind of the life cycle of, let's say, a woman's estrogen levels. She's going to be relatively low, prepubescent, and then she's going to be fairly normal, we hope, in her reproductive years, and then she's going to hit menopause, and then you're going to then potentially introduce HRT. And to some degree, you're going to raise these hormone levels back up, maybe not all the way to young, healthy levels, maybe in some cases higher, in some cases lower, but you're going to be adding hormones into the mix. And if you do it perfectly, this is the first big caveat, is there is still not simple equivalency between a young healthy value and an on HRT value. Okay, so we're going to go through the different tests and just kind of look at what are the best uses for these tests. Just kind of my general overview. When you're talking about saliva, really one of the primary advantages of saliva is you can test it multiple times throughout a day for the free cortisol, throughout a month for mapping out menstrual cycle patterns. When you get into a single measurement, like I want to measure on Tuesday and see what my hormone levels are, I think it's less accurate for the sex hormones because the technology, just the levels are so low in saliva that it's pretty tricky, but it can be okay in those situations. But ideally, where it works it's at its best is when you're mapping hormones out throughout the day or throughout the month or whatever. For serum testing, if you want a single hormone, a progesterone, maybe a free and a total testosterone, something like that, serum's a great place to get that. Obviously, it's if you're measuring vitamin D and all these other peptide hormones, serum's a great place to do just your general blood testing. If you want a comprehensive overview of especially sex hormones, a 24-hour urine test is good. And then a test I want to introduce you to is called Dutch, and I'll explain what that is here in a minute. But that's a really comprehensive way to look at sex and adrenal hormone profiling. And what this is, I'll just explain it briefly so you know what we're talking about as we move forward. It's based on, if you want any test that's just basic. So estradiol, testosterone, progesterone for sex hormones, DHEAS, maybe a one-time cortisol. That's kind of the foundation. And as I said, you can get those anywhere. You can get them in saliva, serum, or in urine. When you want to look more comprehensively, that's where you kind of have to start picking and choosing. Instead of just testosterone, I'd love to know about DHT production. Instead of just estradiol, I'd really like to know about not just estrone and estriol even, but the hydroxyestrogens as they relate to estrogen metabolism, potentially, things like breast cancer risk. I'd like to know that. When we're looking at the adrenals, we want the daily free cortisol pattern is huge, but we'd also like to see metabolized cortisol. And we're not going to talk too much about adrenals here, but the point is, you can get a lot of that stuff in urine, but the free cortisol pattern you can usually only get in saliva. And so when I look at a 24-hour urine, that's got the most information, but it's missing the daily free cortisol and the easy patient collection. So where this Dutch test came from is looking at the fact that you can actually get the free cortisol pattern out of urine as you do in saliva. So if you pick your samples appropriately in terms of the timing and the way that you do it, you can actually get that same information. So in this study, they were looking at controls and chronic fatigue patients, and they got the same patterns either way. So we use dried urine samples in this case just because it's easier and it's entirely accurate relative to a liquid urine sample. And so patients are just, collecting on filter paper once, twice, 3 times, 4 times throughout the day. And from that, we can get the diurnal cortisol pattern, but also an equivalent to a 24-hour urine test for all the other hormones. So now you've got a dried urine test for comprehensive hormones, and that's where the name Dutch comes from. So we're able to get all of this. This adrenal piece is actually really interesting, but not for today's chat. We're looking mostly at stuff related to HRT, which is more of this bottom piece of expansive panels of estrogens and androgens as we look at monitoring HRT, and compared to the other tests, you're just getting more information. That's the whole point of this test. So just to give you an idea of what that is. So as we're looking at serum, saliva, 24-hour urine, and then this other urine test, what I find is that with the sex hormones, when we're looking at baseline testing, serum testing works really well. With saliva, it's okay, but you have to be really careful about which labs you're using because there are some pretty inaccurate methods out there for testosterone and estradiol especially. 24-hour urine can be great. Problem is with serum and with 24-hour urine, you're really missing a lot for the adrenal piece, which is where saliva excels with the free cortisol pattern. And that's why I like this particular method for baseline testing, because it gives you all that in one picture. But when we start looking at HRT, and that's the point of our talk today, is it really depends on the route of administration as to what's going to excel. We've got oral, we've got vaginal, patches, sublingual, transdermal, and each one of these is unique. So as we look at this piece of this testing matrix, and we're looking at oral progesterone, oral estrogen, what we see as we compare serum, saliva, urine, and this other form of testing is that it really depends. So the concept here is if you see black, that, kind of a simple way to say this is if you see a black mark on here, according to the data as I see it, is you're probably better off not testing than trying to make sense out of these results. If you see more of the orange, that's where there's limited value, where you can get some benefit from the testing, but there are some caveats, and you've got to be careful. And then where you see the green, those should be pretty good situations. So let me give you a quick example. Actually, let me just hit this first. So the general concept that we're kind of basing this off of, whether we sort of define it this way, I think, or not, is that we have hormone levels within the normal range. Let's say a woman's progesterone is, within the normal range. And then she hits menopause and she's going to be, below range. So you can be below range and have a legitimate deficiency, or you can be above range and have a legitimate excess, right? So once we introduce testing, then let's say I give a postmenopausal woman not enough progesterone, I'm going to have a deficiency. If I give her too much progesterone, I'm going to have an excess. And that's the whole point, obviously, is we want to give enough. So if we don't give enough, everyone's low. If we give too much, everybody's high. If we give the so-called just right dose, some people are still going to have a deficiency and some people may have an excess. Otherwise, we wouldn't need to test. And so we want to test and see, okay, how do you look relative to what we're expecting? And then we can adjust the dose. The thing you have to watch out for, and this is sort of a cutesy way of saying this, but is what I call testing minions. And what a testing minion is anything that wreaks havoc on your ability to make sense of the testing value. So if something is introduced into this whole scenario that increases the lab value, and that's not representative of what's going on systemically and at the tissue level, that's not a good thing. And likewise, if you're getting a value that's lower than what's really going on, that's not good. So in those cases, we've got false lows and false highs, and we need to watch out for those. So we need to avoid these situations where the lab values are misleading, which we just refer to as our testing minions. So let me give you an example of that that's really easy to follow. So if you look here in the middle here at sublingual and saliva, this is a pretty easy scenario. It's contaminated in the mouth, obviously. So what happens is you give this just right dose, but of course the value is going to go sky high because the difference between the hormones in your saliva and the hormones in the supplement is literally a billion-fold difference. So when you put that into your mouth and then try to measure hormones in your mouth, it's not going to work because you've contaminated the sample. We're going to have to go somewhere else for testing. Now with sublingual, as it turns out, this is one of these where I'd say there's really questionable value in testing as it relates to adjusting the dose. Blood testing goes up and down so fast that it's really difficult to test. 2 hours, it's up and it's down. So you're either shooting at a moving target or it's already gone. That's not helpful. With saliva, you're contaminating it. That's not very helpful. With urine testing, it would work very well, except if you swallow a decent percentage of it, you're going to get first-pass metabolites in your urine. The values will be bloated, artificially high, and that's not very helpful. So that's a situation where it's very difficult to find a test where you can give a hormone, measure the hormone, and then change your dose based on that value. With sublingual hormones, I think you need to lean a lot more heavily on research in terms of what dosing you're going to start with, and then patient symptoms and other things to really figure out how to best optimize what's going on there. So let's just go through a couple in detail, and I'll give you some resources at the end that have more detail on each one of these as we move along. So let's talk about oral progesterone. This one's really commonly misunderstood. So when we look at sort of my rating for these, it seems a little bit harsh to say, okay, you're telling me that serum testing doesn't work, saliva testing doesn't work, and a 24-hour urine test doesn't work very well. Here's why. Typical testing is of questionable value. In serum of saliva, the return to baseline is too fast, and most tests are inaccurately high. So let me show you the data. So if you've got a postmenopausal woman, she's at 0. If you have a premenopausal woman, she's going to be somewhere in this range, right, about 10 to 20. Okay, so with a typical progesterone assay, an enzyme amino assay, sometimes you call that an ELISA, you get a value 2 hours after supplementation of about 12. If you retest those samples with a mass spec assay, which is a more accurate method, you essentially get a baseline value. You get 0. So the values, one important thing to see, it doesn't go up very high. It doesn't get anywhere close to premenopausal values. So what we've got here is we've got a testing minion at work, right? So this value here is a false positive. So is there any reason, again, it's cross-reactivity with the assay with progesterone-like molecules that are created from the extensive gut metabolism that goes on. Does that value have meaning? I don't think it does, because even with the same exact sample, depending on which immunoassay you use, depending on how you metabolize it, which of those metabolites is going to cross-react at different rates, it's essentially an arbitrary value that just confirms that you took your progesterone. So that value is not meaningful. The real value is down here at 0. And you say, well, does oral progesterone even work? It does, because a lot of the metabolites that you create are progesterone-like, and they'll have an effect that is progesterone-like. So studies have been done. You take 100 milligrams. It balances your estrogen, even though the progesterone itself doesn't reach the levels that you need to balance the estrogen. So for, if you go back into the 80s and they're using this old technology, you find all these studies where, oral progesterone hits 15, hits 10, hits 20, and those values are really not very meaningful. So to chase that value to a certain number with a dose of progesterone doesn't really make a lot of sense. Same with saliva. You're going to get potentially a value that's elevated, but think about this. When are you giving this? You're going to give it at night, right? Go to bed. When are you waking up? Over here. You've missed everything that's happened in here anyways, but the value that you see right there is just residual cross-reactivity. So if you push this number up and up and up, it doesn't make a lot of sense. And then if you happen to have a lab that uses a more accurate mass spec value, you definitely don't want to push that to a certain target value with more and more oral progesterone. It just doesn't make sense. So that's from Fertility and Sterility in March 2000. With urine, what do you get? Small doses don't raise serum levels of actual progesterone. We saw that, right? But they lead to very high urine levels because you're measuring a metabolite, right? So you can get some information from this that's helpful because the metabolites are what's creating a lot of the clinical effect. Does progesterone help you sleep when you take it orally? No, not really. Allopregnanolone is what helps you sleep, and of course you make that from your oral progesterone. So here's a woman taking it vaginally, she gets almost nothing. Take it orally, and it's sleepy time. She's going to have a lot of help from the oral progesterone, and those metabolites are what we can see in urine. So here's what I find somewhat helpful, and I'll just go through this real briefly, is in urine you're measuring 2 metabolites. Or you can measure 2 metabolites. Most urine labs don't, which is why I don't score that very well, is this beta pathway is pretty much inert in terms of its biological effect compared to the alpha metabolites. So these alpha metabolites, that pathway includes alpha or allopregnanolone. So if you look at these 2 women, they push down the beta pathway the same, and that's the value that you get from most 24-hour urine labs, which is why I say there's really no value in that. Okay? But if you look at these 2 women, the one on the right really pushes down the alpha pathway much more than this one. So this woman over here is going to need a higher dose to get the same clinical effect, whereas the woman over here on the right is getting tons of this alpha, and you don't want too much. So here's a woman who might be able to scale back on her dose, and the woman on the left maybe needs to take a little bit more. So all that to say, there is some interesting information that can be had if you think your way through it a little bit more and test a little bit more extensively, and I think that can be of some value when you're looking at oral progesterone, but I think you have to be really careful with what values in serum and saliva really mean just for that particular scenario because of the way things go with oral progesterone. Now, the other case that's really quite complex is transdermal HRT, and this is so hard because it's so popular, and we really want something to work well. And my position is really that nothing works super well with transdermal HRT, so it's better that we just know that. We can make some different decisions about how we test, but really when you're looking at transdermal creams, I think this orange score, which says it's okay but not great, is actually pretty generous. I think it's really difficult to use testing to really tweak a particular dose when you're talking about transdermal hormones. So can it help monitor dosing? It's questionable, I think. So the short story is you get a little bit of an increase in serum or urine, which is probably an underestimation of tissue levels, and you get this massive salivary increase. But it's way too variable to monitor dosing effectively, and it probably doesn't reflect systemic tissue levels if you really dig through the data. That's where the data has led me. So if we want the longer version, I'll try to go through this quickly. I've got some video resources that you can kind of dig through on your own if you want more of the details. But, as we said, the increase in concentration depends on where you look. Not much in urine, not much in serum, a ton in saliva. So it's two different messages depending on where we test. So in this study that I was involved in a few years ago, we looked at percutaneous, which I'll just put transdermal in here, transdermal progesterone delivery. We looked at serum. We looked at venous whole blood, saliva, and then capillary blood, which is just a fingertip blood spot. Okay, here's what we found. After dosing, over time, the serum values go nowhere, which is what will happen with the urine as well in this situation with 80 milligrams. And the blood spot and saliva went way up. This right here is an 80 to 100-fold increase right in here. That's a huge, massive increase. Right? So saliva correlates reasonably well with blood when you're not supplementing. So does blood spot. When you take transdermal hormones, they tell two completely different stories. So typically we're asking ourselves, well, which one of these is correct? And I think as you look at them really at all the data and evaluate each one individually, none of them really work well enough. The saliva reality to me is that it teaches us that some tissue have more hormone than is reflected in serum or urine, but it probably doesn't reflect systemic levels, and it's not effective in monitoring HRT. And this is the data. There's a lot you can go through on this, but this is really the crux of the data to me. When we did this study, buried within the study was this. We had someone taking hormones in a controlled setting. We had a third party applying the hormones with gloves. We're putting it on the inner thigh, so it's in a place where contamination is totally minimized. Okay, we put it on one day, we collect 24 hours later. We put it on again, we collect 24 hours later. There were other measurements in this study to look at different things, but when you simply ask this question, when I test on Monday and then on Tuesday with nothing changed, same variables, same dosing, same timing, same everything, do you get a reasonably reproducible value? And you don't. When you look at blood spot and you look at saliva, these values are huge. They're very much increased over, that's like a baseline value in blood spot would be less than 1. Okay, a premenopausal level would be around 10, 15, 20. Okay, so look at these values. So if you look at patient number 7, this is what we'd hope to find. You find a 9 and a 10. Hey, that's pretty good. When we look at the saliva, premenopausal values are in the 100s, 200s. When you supplement with topical progesterone, it can get up into the hundreds, thousands, that sort of a thing. And what we see is a moderately increased level. So baseline value would probably be in a postmenopausal woman would be around 20, 30, 40, right? So 160 and 310. For patient number 7, we get a reasonably reproducible value, and it's reasonable agreement between blood spot and saliva. It's really the only patient that that's true for. Look down at the next patient. In the first collection number 1, we get almost a 50 in blood spot. We say, whoa, that's a really, really high value. But when we look in saliva, we get a relatively low value. You say, okay, 2 different tests, 2 completely different messages. Okay, what's reality? Let's test again. So you collect 24 hours later, and look at that. The blood spot's down 10-fold. You say, oh, okay, I guess the saliva was right? But look at saliva. It went up 10-fold. Right? So, A, they don't agree with each other, and B, they don't agree with themselves from day to day. Right? So if you look at this, the replicate values that differed by 5-fold, more than 5-fold, are 1, 2, 3, 4, 5. And with blood spot, it's 1, 2, 3, 4 out of 12. Okay? So that's really not good enough to say, I'm going to test, I'm going to get my value, I'm going to change my dose, because if you don't change your dose, chances are that value is going to change dramatically anyway. So that's not, there are other issues we could dig through here about, does this really reflect tissue level and all these things, but at the base of it, if you can't get the same value reproducibly, it's not going to be useful. But it does tell us, every one of these values is far above a baseline value, every single one of them, right? And in serum or in urine, you don't have much of an increase in this same scenario. So what it tells us is, there's this profound message that saliva and blood spot tell us that when you put a hormone on the cream, it gets somewhere, more so than you see in serum or in urine. But you can't chase lab values with topical creams. I just don't think that makes a lot of sense. I think you end up either spinning your wheels with saliva testing, or in serum or in urine, you can end up overdosing if you're not careful. So just know that when you're dealing with transdermal products, and just, not to get into it too much, but when you're using alcoholic gels, you can get much more of an increase in urine and in serum, and it can work a little bit better. And in saliva, it's about the same with the gels and the creams, but the alcohol tends to get it, I think, to places where the creams do not. So if we're looking at a transdermal cream, look at this testosterone. This is way low for urinary testosterone. He's on transdermal testosterone. But see, I can look at these and say, okay, if testosterone gets into a cell, what's going to happen? It's going to get metabolized to DHT to some extent, and then that's going to get metabolized to androstenediol, and that's what's going to get excreted. See how high these values are? I think that's reflective of some tissue uptake here. So I can look at that and I can glean some information from it, and I would look at this testosterone value and say that's probably an underestimation of what's going on. Is that useful? It's moderately useful, but you have to be really careful. Okay, so why would we want to test in urine for the estrogens? That's because we like these metabolites. This can be a helpful added information. So the one we don't want to see, if you're looking at metabolism, you've got 16 hydroxyestrogens, 4 hydroxyestrogens, and 2 hydroxyestrogens. This is the preferred pathway because those metabolites have more anti-cancer type properties. The one we don't want to see predominate is this 4-hydroxy. The 4-hydroxy makes a quinone. If it makes a quinone, it can actually attach to DNA, damage your DNA. When they measure this 4-hydroxy adenine or guanine, the piece of the DNA as an adduct, you can see that women at high risk for breast cancer, women with breast cancer, make a whole lot more of those than the supposed healthy controls. So looking at the metabolism can really help you in terms of safety, in terms of making sure that the estrogen's going where you want it to go, and you can intervene nutritionally. If it's not, you can also look at the methylation pathway and take a look at that. I think that's good added extra value. And so that's one of the benefits of urine testing. So especially in some of those cases, like with topical or sublingual, where it's really hard to get a handle on the dose, at least you're getting some information on what's going on with a patient, and you can make some adjustments there. But again, what were our objectives? Understand the need for testing, the 4 different types of testing, and the limitations, and they all have limitations, and that's a big message. They all have limitations when you're dealing with HRT, and we need to understand the effect, because it's profound, on the route of administration when we're working with this. In terms of understanding the need for hormone testing, why do we test? I mean, we want this to work well, right? We want good efficacy. We want to minimize associated risks. We want safety. There's some just practical issues of, liability and those sorts of things. And then we like our patients to believe in what we do, so we want to be able to see them that I'm giving you this hormone. It's having some effect. So these top 2 are the 2 that I'm really concerned with. Is let's make sure this works and let's minimize risk. And the goal in doing that is not just to get a number. It's not just to get a number that happens to be higher than the previous number. The goal is always to get meaningful numbers. And when you look at this chart as sort of my attempt at creating a guide to help people with that, to say, look, in what cases do we need to not lean very heavily on the labs? If you are a serum tester, the oral progesterone value, I wouldn't put a lot of stock in that, but an oral estrogen value actually works pretty well. And when we're talking about vaginal hormones, you have to be careful because the rise and fall of hormones can be very unpredictable. So if I get a low value, it might mean I need more hormone. It might also mean you missed the peak. So be careful there. But when you use a patch, those values should be stable. They should be steady. It's totally different than transdermal creams and transdermal gels. It goes up in a linear dose-dependent response. You can lean more heavily on that serum result as you're trying to figure things out. With sublingual, the kinetics are too fast. With creams and gels, I don't think it's very useful. So, for each of these, you have to kind of work your way through it and figure out what works well when. And that's why part of what we created with this Dutch test is an attempt to be as much of a catch-all as we can. We have a special method to help with vaginal hormones. We've got the extra metabolites to help with oral progesterone. But there are, still, with that, in our best attempt, with sublingual and transdermals, it's still pretty tricky, and you've got to lean less heavily on the labs, if at all, in those situations. So again, we went through this. We're running short on time, so let me just skip through this. For each of these, I've made a short video, so I want to point you to this section. So I've got this video series. If you want more detail on it, give me more detail on what are you talking about with vaginal hormones and the kinetics. So I've got the studies and we can look at those. So if you want to look at those, go to precisionhormones.com and you can look at whichever video speaks to the particular issue that you might be trying to solve. If you have some questions for me, feel free to email me at mnewman@precisionhormones.com, and I thank you for your time.